My question, I've got two related questions actually, just to steal the microphone for a moment. The age distribution chart that you showed and the prevalence of CLL being in the older category, with the availability of tests now for various conditions, do you foresee that graph shifting to the left and more people being diagnosed at a younger age? That's question one. And then secondly, with the new treatments available, do you see the watch and wait period being reduced and therefore treatment, the decision to treat, being introduced much sooner? So one of the things I had difficulty with at 30 when diagnosed was the idea that nothing would happen, we would just watch and wait. The treatment options were quite serious and could cause more harm than benefit, and therefore watch and wait was the only solution. But with these new treatments now available, is watch and wait going to be squeezed?
So, first question, the more, I think the answer to the first question, whether the incidence of CLL has increased, it is very much right that the technical tools that we can use can identify what is called the CLL-like clone much more easily. And this has brought certainly to the identification of that category called monoclonal B-cell lymphocytosis in much higher numbers. The overall frequency and distribution within age of CLL actually has not changed that much. There are more rise stage 0, the very early stage, but there is actually within the current circumstances of the NHS a fight between who are the patients who we need to bring to clinic and actually make the diagnosis of the L word. Do we really need it? So there is a gray zone that still remains in which at the end we really try and see, depending on availability of service, it's unfortunately the practicalities that sometimes some patients with a low count come to us, we make the diagnosis. Some other time we advise the GP to say, wait, there's nothing to alarm the patients, let's monitor the lymphocytes, let's see if they have glands. So I don't think the incidence has massively increased. It's certainly the most common condition. The second about watch and wait. So watch and wait, there has been an active approach into, and Renata probably knows a bit more than me about that, an active approach into trying and see whether patients with a diagnosis of CLL deserve treatment before they get symptomatic. So to shrink the time from diagnosis to active intervention with novel molecules, particularly with ibrutinib. And there was a trial run in Germany for this. And there has, like it has happened before many decades ago with chemotherapy, it's been documented that there is no advantage. There are actually addition of complications if patients are treated earlier. So I don't think that the watch and wait period is expected to be changing. Personally, I am sort of the old school to resist, always resist, and consider treatment for CLL only when that is really needed. Drugs are, by definition, meant to give good effects and bad effects, and still we need to learn whether in some situations the bad effects are worse than the other. But probably we want to listen to the opinion of the other doctors.
Yeah, I mean, obviously that idea was investigated decades ago. So first was late Professor Katowski did in 1980s, giving chlorambucil earlier, no change. Then there was a German study group was giving, believe it or not, FCR to those patients early again. And obviously those are poor risk because you know people with the mutated IgHV with good CLL wouldn't be eligible for that study. So they were picking poor risk patients. And again, there was progression-free survival has improved, but not overall survival. And as Francesco mentioned, the most recent trial, which was CLL12, which kind of logically you think, well, if we go with the targeted therapy and we choose those really, really poor risk patients, so you've got a really low burden of disease, you go with really exquisitely effective treatment which just goes after the B cells, so low volume, very accurate treatment, although none of the drugs are accurate, but let's park it for time, surely will work. And we actually, we saw some deaths in the group of patients where we would not normally treat them. So it was actually heartbreaking to see Dr. Langerbeins, who was presenting that data, almost, when I asked her, what if she was presenting at the UK CLL Forum, what next? It was you could almost see us were breaking down crying, because obviously, that's what the clinical trials are for. There were patients who probably should not have died. But, that's why we're doing the trials. So I think that especially German study group probably parking that idea. But when you go on the clinicaltrials.gov, there are a number of studies still ongoing using venetoclax combination, using acalabrutinib combination, sort of fixed duration, maybe fixed duration is better, looking how that fixed duration may improve, for instance, response to vaccinations. So the work is ongoing, but as Francesco said, I can't see the watch and wait being shortened in any time soon. I think I'll retire first before if that happens.
And you're very young.
Thank you. I'm going to take a question that came in from our Zoom attendees. Is there any significant change in long-term efficacy of venetoclax at 400 milligram dosage or 300 milligram?
The short answer is we don't know. There's actually this study that with the longest, the Venice 1 trial with the longest follow-up of patients treated with venetoclax, in which we have actively participated and led the study internationally. And the change of dose didn't really seem to make any significant difference when venetoclax is used as single agent. In practical terms, it happens that we do often reduce the dose of venetoclax because we don't sense a difference between the 300 milligrams and the 400 milligrams. We play a bit as doctors in defense. We have to be very honest in that as well. So there is a solid attention to something that I don't like, which is the guidelines. But we have to comply with them. That's why people who are really expert design the guideline to make them the most efficient, and this is Renata. But personally, I don't see the significant difference in terms of efficacy between the higher doses.
Yeah, I think the other thing to add. So when the dose is designed, they're looking at pharmacokinetics. 13. Obviously, I don't have at my fingertips what the level of drug is at 300 and 400, but I would imagine the levels are pretty close. So I don't think probably there will be much. But it's pure speculation.
One of the reasons I asked the question which came in was that's exactly the situation I'm in. I was reduced, so I was classically asking it on behalf of a friend. But the reason my dosage was reduced was I was having a lot of infections, and it improved my ability to fight those infections. And I haven't had infections since, without any degradation in my results. So this is the margins in which you can work in, which goes back to the individualized treatment.
And mind you, the fact that the dose is reduced comes out of some flag saying that the drug is there at amounts that exceed the needs. When toxicity comes, it's a moment that tells that in which your body says, I don't need it as much, I don't want it as much. So it's as possible that while it is toxic to some extent, it's actually probably overactive to some other extent. So when we make this decision in reducing the dose, it's because there are signals that tells us that maybe an individual who's 110 kilograms or 16 stones will benefit from a reduced dose opposed to an individual who's 10 stones. So it's always hard to define the relative dose for an individual. We just give 400.
I'm going to steal a little bit of time from lunch to try and get some more questions in.
I can probably
It's just for the people online as well.
Thank you all for your help in our illness. I hope I can make my question, which would take days to ask, into some concise matter. Professor Falcone, thank you very much again for making a very complex biomedical subject relatively simple.
I thought I did the opposite. I thought I did the opposite, but
Well, I refer back to, was it the Southampton conference, which you both were at? Again, you had a team there, your team was, and you talked about a subject you brought up today again, which I think I'm going to try to refer to, and be wrong, because I'm a social scientist. Bioscience, I'm sorry. The only thing I'm interested in that is my wife. She has a bit of that. I suppose you're referring to as IgM. Well, my question is in the field of heterogeneity of CLL and the reference to environmental issues which impact on it, which is not your field, the environmental issues, which is my field. Since I've been banging on about it for 10, 15 years to CLLSA, that we have to talk psychological and physiological input into the person, is the mutation, if I'm saying it right, the question, of IgM into a active CLL cell, would that be a way to say it? From a passive cell, which refers both to the onset of CLL and also relapse formations.
So what tells us that there is an engagement with elements in the environment, pathogens, is in normal B cells, it is the levels of the immunoglobulin. If there is an active engagement of it's called antigen receptor, B cell receptor, the immunoglobulin, then the cell operates in a way that needs to bring the antigen in, the pathogen in, so that by bringing it in with the B cell receptor, there are machineries that will expose it back to the other cells of the immune system called T cells. So there is a biological mechanism by which engagement equals bringing the levels down. It has nothing to do with the presence of mutations or not. It hasn't got to do with the mutations. The mutations are another consequence. So you are right in thinking that the environment has always a component. Now, as people who look at the body stop at the environment within the body. But what is brought from the outside to the body to trigger a reaction, which is the same reaction that leads to an infection initially, can be a common pathogen, we think. We don't know if it is something very specific. And in Southampton, we are looking for the structure of the receptor and its mutations to try and see whether there is something shared between one individual with a CLL and another individual with a different CLL. It's a very big open question. There are lots of investments. I must say more from Europe than from than from the UK in trying to understand what is the structure and what is the driver from outside the cell to the transformation into CLL. But still we don't know.
How much a factor is the immune system in preventing that transformation?
So this is a general question, and again, from a clinical perspective, there is a lot of activity in building. For example, Renata has made a booklet on vaccination of patients with CLL, because the more the individual is immune suppressed, the more the individual is generally is at risk. Now, the risk is of infections. Then, if the immune suppression is a consequence of CLL, which it is, or if it is CLL a consequence of immune suppression, which is possible as it is in many other cancers, that is again the question of what comes the egg or the hen. But there is certainly a dual component of one supporting the other, immune suppression to CLL and CLL to immune suppression.
If I could just quickly add about the booklet. So the actual booklet's been updated on a regular basis, and you can find it on CLLSA website and the publications.
Advert.
Thank you, John. Thinking about second-line treatment, which is funny, I know it's coming, but I'm not anxious about it, like I was during Watch and Wait. So what questions do we ask you folks to help us know what is the best second-line treatment?
What?
What do we need to know? What questions do we need to ask our consultants? Is it about the mutation, the unmutation,
Okay, I'll answer that. Hi, my name's David Dutton. I'm one of the new consultants at Southampton. I think my name has been mentioned a couple of times, so it's nice to see all these faces here today. It's a pleasure to be asked along. I think that's a really good question, isn't it, about how you get to that point of approach. What am I going to need, and what do I do to prepare myself? So I normally say a couple of things when I'm in clinic. One thing is a period of what I call pre-habilitation, and that's preparing myself physically and psychologically for that point when, and I say when and if, depending on where we are in the stage of the disease. And that means keeping fit, the immune system, keeping prepared, keeping vaccinated, and being ready for that point. And then the questions we all then come up when the disease is starting to progress is to say, well, what are the opportunities at that point? The treatments, we've said they are going to change as time goes on. Clinical trials, are they going to be available? Because we want to offer the best opportunities to you if we can do as time goes on. And then often, now one of the big decisions is between time-limited therapies, and that's in the second line, that's usually using venetoclax if you haven't had it beforehand, although we can repeat it, or whether an ongoing therapy. And that can relate back to the immunogenetic status and the other genetic status of the disease. So often at that point, if the disease is coming back, then we'll consider retesting some of the genetic status. So you might want to say, well, have you rechecked those genetics? The mutated or unmutated status doesn't change, so we won't recheck that, but some of the other genetics we will check. So those are the things you want to be saying is, am I fit enough? Saying that to yourself. How can I improve my general health? To us, are there any opportunities for novel treatments? Have my genetics at the point of retreatment? Have they been rechecked? There we go, that's better, isn't it? And I think really those are the things I'd say off the cuff. I don't know if my colleagues have got anything
Yeah, I
else to
just
say
want to
there.
really thank you, David. I think I'm really passionate about prehab. We all have heard about rehab. The rehab is essentially too late, because rehab, it means fixing you up after the insult. and prehab is very important. And I think I'll want to hand over to Bryony, because you at least do what you preach, and tell us, how do you approach prehab and how do you guide the patient before the treatment?
Thank you. Exactly that. Just encouraging people to stay fit. Good diet, not too much alcohol, definitely not smoking, things like that. Just helping people to live a better lifestyle and manage their own sort of health at home. And we can always help with that. And the groups like the Rambling that Nora does, getting in the groups, and the charities, they have organised groups, and walking, and just generally being fit and healthy is what we try and encourage.
I sometimes ask patients as well to, if they have a good general practitioner, is to focus on those cardiovascular complications, those factors. So make sure your blood pressure has been checked, is well controlled, diabetes, if it's there, is well controlled, because if we are using the BTK inhibitors, this group of drugs such as zanubrutinib, acalabrutinib or ibrutinib, then I think the fitter your heart is before you start, often the better things will be.
We did a webinar with David Bartlett in December, an exercise one, and as a follow-up to that, we're working with him. We had a meeting last week, and we are looking at aspects of prehab that we can have, resources that we can make available through our website. I'll ask one more question here from the Zoom people. Given the significant differences between the physiology of men and women, why aren't more studies looking separately at treatment results for each gender instead of lumping us all together? Or are they?
Positive.
So I have, someone gave me the microphone. Now, equality and diversity. So CLL is slightly more common in the male population than in the female population. But there is really not a difference in frequency to justify that the two genders should have a CLL that is pathologically different in the two genders. Looking at the B-cell receptor, there is actually one very strong peculiarity that puts the idea of, I'll put it in scientific terms, of natural antibody producing B cells, which are those B cells that always hover around, ready to attack from the very early period of our life throughout, to attack the immune system before an immune reaction actually happens. That is very much skewed towards the male gender. It's one specific gene. You actually made a publication about it, discussing whether it is more used or not in the male population, and it is 169 gene, that's what it is called. It's a segment of the B-cell receptor. So to say that if there is a biological interpretation to be made between genders, the B-cell receptor tells us that the most aggressive disease might be found in the male, explaining the ease of finding the condition, of documenting the condition more frequently in males than females. But overall, there is no other massive difference, even at the different ages, between male and female to justify a separation of studies. On top of that, while before the treatments were considering environmental, so the patient on its own, now the treatments are very much oriented towards the specific condition and less oriented towards if a patient is older, if the patient is of a different gender, if the patient is in working or non-working conditions. All these factors have been actually been attenuated with the new medications.
Thank you.
Yeah, maybe just really quickly, just to add what you already said. I mean, obviously, when you presented the Colonel-Bruton, actually, it's an X-linked disease. So it's that disease where there is no complete lack of B cells, has been described in boys only. So you don't see that in females. As female, I'm sorry guys, our life expectancy is better. That's a fact. And therefore, actually...
And fitter.
Females generally do better because, with any actually treatment. And just one more thing, if we start splitting, the important thing to look into it are those tricky, poor risk patients. Like sadly Lewis was one of them. And when, we don't have that many patients, and when you start splitting too much, you're basically losing the message. And I think, overall, the CLL is more common in Caucasians. I mean, we know that the other groups are, yes, there, and you can see other ethnic groups having CLL, but it's not as common. But I think overall, as you said, I think let's leave status quo as it is. I think we've got really fantastic treatment, and today is all about the non-chemo type of stuff, which is really amazing.
The final question before we break for lunch goes to the boss.
Just before we go to lunch, Renata, as all of you ought to know, Dr. Valeska is the chair of the UK CLL Forum, and I, as the chair of CLL Support, sit on the executive group of that forum. There are 35 of us on that group. So I was asked to provide my CV to put it up on the forum. And in writing my CV, I can see she's smiling, I was asked to include at the end of it the various physical activities I got involved in order to make sure that I was keeping fit and healthy. And this is a request that is made of all the clinicians on the UK CLL Forum. So not to patients, but to all the clinicians. So I just think you ought to be commended for walking the talk, absolutely doing what you believe in. So thank you.
Okay, we are going to